Delayed neurologic deficits. There are four major causes of delayed neurologic deficits: re-rupture, hydrocephalus, delayed cerebral ischemia, DCI, and hyponatremia. 1. Re-rupture. The incidence of re-rupture of an untreated aneurysm in the first month following SAH is 30%, with the peak in the first 7 days. Re-rupture is associated with a 50% mortality rate and poor outcome. Early treatment eliminates this risk. 2. Hydrocephalus. Acute hydrocephalus can cause stupor and coma and can be mitigated by placement of an external ventricular drain. More often, subacute hydrocephalus may develop over a few days or weeks and causes progressive drowsiness or slowed mentation with incontinence. Hydrocephalus is differentiated from cerebral vasospasm with a CT scan, CT angiogram, transcranial Doppler, TCD, ultrasound, or conventional X-ray angiography. Hydrocephalus may clear spontaneously or require temporary ventricular drainage. Chronic hydrocephalus may develop weeks to months after SAH and manifest as gait difficulty, incontinence, or impaired mentation. Subtle signs may be a lack of initiative in conversation or a failure to recover independence. 3. Delayed cerebral ischemia. Vasospasm is the narrowing of the arteries at the base of the brain following SAH. This may cause symptomatic ischemia and infarction in 30% of patients and is the major cause of delayed morbidity and death. Signs of DCI appear 4 to 14 days after the hemorrhage, most often at 7 days. The severity and distribution of vasospasm determine whether infarction will occur. A vasospasm is believed to result from direct effects of clotted blood and its breakdown products on the arteries within the subarachnoid space. In general, the more blood that surrounds the arteries, the greater the chance of symptomatic vasospasm. Spasm of major arteries produces symptoms referable to the appropriate vascular territory. All of these focal symptoms may present abruptly, fluctuate, or develop over a few days. In most cases, focal spasm is preceded by a decline in mental status. The vasospasm can be detected reliably with conventional X-ray angiography, but this procedure is invasive and carries the risk of stroke and other complications. TCD ultrasound is based on the principle that the velocity of blood flow within an artery will rise as the lumen diameter is narrowed. By directing the probe along the MCA and proximal ACA, carotid terminus, and vertebral and basilar arteries on a daily or every other day basis, vasospasm can be reliably detected and treatments initiated to prevent cerebral ischemia. See below. CT angiography is another method that can detect vasospasm. See severe cerebral edema in patients with infarction from vasospasm may increase the ICP enough to reduce cerebral perfusion pressure. Treatment may include mannitol, hyperventilation, and for intractable cases hemicraniectomy. Moderate hypothermia may have a role as well. 4. Hyponatremia. Hyponatremia may be profound and can develop quickly in the first 2 weeks following SAH. There is both natriuresis and volume depletion with SAH, so that patients become both hyponatremic and hypovolemic. Both atrial natriuretic peptide and brain natriuretic peptide have a role in producing this cerebral salt-wasting syndrome. Typically, it clears over the course of 1 to 2 weeks and, in the setting of SAH, should not be treated with free water restriction as this may increase the risk